All right, so we're going to talk about some issues associated with vital signs. And so, ideally, what you would have is you'd have a baseline for your client's vital signs. But we want to go back and we want to just review some of the physiology of what controls things like blood pressure, heart rate, respiration, and then we can start adding in how pathologies affect these things. So I wanted to start off with a review from your physiology and then just show you how we can, with our understanding of what controls blood pressure and heart rate, how we can start to think about things that might affect that. So back in A&P, you learned about blood pressure control. And so we're just going to quickly go back and look at that. So what I have here is I've got the heart, and then the heart has the arch of the aorta. All right, so I have the arch of the aorta. Coming off of that, I've got my brachiocephalic. That's going to bifurcate into the carotid and the subclavian. And then likewise here, I'll have my carotid, and then I have my internal and external carotid arteries. Okay, so what's happening is you have what are called baroreceptors. And baroreceptors, you have sensory fibers of the glossopharyngeal nerve, but also sensory fibers of the vagus nerve. So the vagal sensory fibers are in the aortic arch. The baroreceptors of the glossopharyngeal sensory fibers are right here at the bifurcation. And so these baroreceptors, what they're doing is they're constantly sending action potentials along their axons to what's called the nucleus tractus solitarius, or the NTS. And so the NTS, nucleus of the tractus solitarius, it is in the medulla, and it's going to be excitatory to what's called the nucleus ambiguous. So we're going to abbreviate that NA. You can look at your notes, and your notes will have this all diagrammed out for you. So this is excitatory here. And then the nucleus of the tractus solitarius is going to be excitatory to the caudal ventrolateral nuclei. And then the caudal ventrolateral nuclei is going to be inhibitory to the rostral ventrolateral nuclei. And so some of the terminology, ventrolateral just gives you the position within the medulla. Nuclei is a collection of neurons. Caudal refers to head, rostral refers to beak or nose. Now, when we look at this, the NTS excites the NA, but if activation of the NTS actually inhibits the rostral ventrolateral nuclei. Well, the NA actually gives rise to the vagus nerve. And so the vagus nerve is your parasympathetic. So the NA is actually your parasympathetic driver for the parasympathetic nervous system. The rostral ventrolateral nuclei actually is for the sympathetic nervous system. And so here I have sympathetic outflow. So normally what will take place is the rostral ventrolateral nuclei, when it fires off, it's going to come down here, and it's going to synapse in the spinal cord. Now, when it synapses in the spinal cord, it's going to synapse in the lateral horns. And so here I've got my cross-section of my spinal cord. And in the lateral horns, where it synapses, I'm going to synapse with these visceral motor neurons of the sympathetic nervous system. So this would be a sympathetic preganglionic fiber right here. That's going to come out, and it's going to synapse in that sympathetic chain ganglia. So I've got my sympathetic chain ganglia synapse. And then, of course, I'll have what's a cardioacceleratory effect. So I'm going to come over here, and what I'm going to do is I'm going to release norepinephrine onto the contractile myocytes. So the target of these is the myocytes. And then the other target I have is the SA node. And this is norepinephrine. And here's the SA node. Now, also, I have coming off here the vagus nerve, I'm releasing ACH. So ACH will also plug into that target SA node. The other thing I have vascular smooth muscle down here. So with vascular smooth muscle, I've got my blood vessel right here. Draw a large vascular smooth muscle. I'm going to synapse here, and I'm going to release norepinephrine onto vascular smooth muscle. And we've talked already about the alpha-1 receptors. And so we know that if we activate an alpha-1 receptor, we're going to get vasoconstriction. Now, if you look at what this controls, when we look at blood pressure, of course, is systolic over diastolic. I'm going to put this, all right, so there's my myocytes. So norepinephrine released on the myocytes is actually your systolic control, because that's the peak contraction. And so there's two ways to increase your strength of contraction. One is Starling's law, to increase the amount of volume within the ventricle. But of course the other is contractility, to increase the norepinephrine release onto the myocyte. And so if we just take a single myocyte and look at it right here, what we've got is is normally what's taking place is I've got gap junctions, and when my SA node depolarizes, I push those positive charges through here. I pop open sodium channels. Sodium channels in turn pop open L-type calcium channels. And so normally I've got my L-type calcium channels over here. They're coming in, plugging into my RYR2 receptors on the sarcoplasmic reticulum, releasing calcium into the cytoplasm of the myocyte, and I'm getting contraction. Well, when I release norepinephrine during a sympathetic drive, so this is happening spontaneous, but when I add norepinephrine to here, what I've done is I've activated a beta-1 receptor that activates a GS protein. That GS protein increases cyclic AMP. The increase in cyclic AMP activates protein kinase. Protein kinase goes and it's going to open even more L-type calcium channels. So now I have more calcium coming in, resulting in more activation of my ryanodine type 2 receptors, and I increase the calcium release into the cell, and so I'm getting a stronger contraction. So again, when I'm looking at blood pressure, we've got systolic over diastolic. What I've done here is I've adjusted my systolic pressure by activation of the rostral ventrolateral nuclei. Now, the bottom number, so there's my systolic is the generation of the heart, but the diastolic is actually the representation of the peripheral resistance. And so peripheral resistance is measured within the vessel right here. And so I can increase my peripheral resistance by releasing norepinephrine onto an alpha-1 receptor, activating a GS protein, GQ protein, and then once I activate that GQ protein, I activate my PLC, IP3, and then I get calcium release from the sarcoplasmic reticulum. And of course, that's going to cause vasoconstriction of the vessel, which is going to increase my peripheral resistance. And so when we put this all together and look at blood pressure, we know that blood pressure equals stroke volume times heart rate times peripheral resistance. And so I can control my stroke volume here at the contractile myocytes. I can control my heart rate here at the SA node, and I can control my peripheral resistance out here at the vascular smooth muscle within the blood vessels. All right, so what we're going to do is we're going to look at how the changes in this system and how it works. So we've got a patient, let's say that, we'll use a simple example to begin with. Let's say I have a patient that's laying down and they're going to stand up. So I've got this person laying down, and now they're just going to simply stand up. So they're going to go into upright orthostasis. Now, when they were laying down, blood was returning to the heart, but it was unopposed by gravity. Now that they've stood up, gravity is pushing down on the blood flow back to the heart. What would happen then is they would decrease their venous return, which would decrease their end-diastolic volumes, which would decrease their stroke volumes. When their stroke volume decreased, that's going to decrease the amount of blood in the aortic arch and decrease the pressure on these baroreceptors. Now, in response to a decrease in pressure, look what's going to happen. I'm going to increase activation here, which increases activation here, which then decreases the activation or the inhibition of the rostral ventrolateral nuclei. And so what happens is the rostral ventrolateral nuclei fires off, and look at this, it's going to go down here, release alpha-1 norepinephrine onto alpha-1 receptors, and a lot of the alpha-1 receptors are actually found in the veins in the legs. And so I'm going to vasoconstrict the veins in the legs and push that blood back to the heart, but at the same time, I'm going to go ahead and activate my stroke volume and heart rate through my SA node and my contractile myocytes. So the response to a decrease in blood pressure or decrease in blood volume is to actually increase heart rate initially. And that's what you're going to see as it tries to correct for that decrease in volume. Now, the other thing to note is that I also, because of the drop in pressure, well, I don't want to have a low heart rate. I actually want to get my heart rate up. So look at what happens to the nucleus ambiguous. The nucleus of the tractus solitarius is going to increase the activation here, which then is going to excite the vagus nerve. And so what I'm going to do is I'm going to end up, because what we did is we decreased it here. We decreased it here, which led to the decreased inhibition. Now we're decreasing it because of the drop in pressure to the nucleus of the tractus solitarius, which then decreases the activation of the nucleus ambiguous, which then decreases the release of ACH. ACH is what was hyperpolarizing our SA nodes, and our heart rate's going to start to increase. Okay, so now let's flip it. Now instead of dropping our pressures, let's look and see what happens when we increase our pressures. So let's say, for example, I have an increase in blood volume. With an increase in blood volume, that's going to put more pressure on the baroreceptors. And so with the increase in blood pressure, what I want to do is I want to drop all of these components. So if we just follow it out here, I increase the blood pressure, I increase the activation of the nucleus of the tracts solitarius, increase the activation of the nucleus ambiguus, which then increases the outflow and release of ACH onto the SA node, and that in turn is going to take the SA node and hyperpolarize it by opening more of my T-type calcium channels and also more of my IF channels that allow sodium to come in. And so right away I'm going to drop my heart rate. But if we come around over here, as I increase the activation here, I increase the activation of the caudal ventrolateral nuclei, and that is going to increase inhibition of the rostral ventrolateral nuclei. So now I'm decreasing release of norepinephrine at the periphery, so I'm dropping my peripheral resistance, and then I'm also dropping my systolic contractions with my stroke volume and dropping my heart rate. Okay, so that's just a review of the control of the blood pressure. But now let's look at what the blood pressure and heart rate are telling you. Because a lot of times when a patient comes in, like I said, it's nice to have a baseline of vitals, either that or have consecutive sets where you can see trends. But sometimes blood pressure and heart rate tell you quite a bit about a patient. So think about this. Think about your patient that has hepatitis. If they have late-stage cirrhosis, alcoholic cirrhosis, Hep C, there's some things that we know right away. We know some of their signs, and we know what their blood pressures would be. In fact, think for a minute. Would their blood pressure with cirrhosis of the liver, would it be the blood pressure be high? Would it be normal? Would it be low? And what would their heart rate be? High, normal, or low? Well, one thing we know is that if I have cirrhosis, I probably also have hypoalbuminemia. Well, hypoalbuminemia creates the oncotic pressure of the capillary. And so if all of a sudden, or not all of a sudden, but over time, if I'm dropping my production of albumin and going into a state of hypoalbuminemia, I'm decreasing the oncotic pressure of the capillary. Now, my normal hydrostatic pressure of the capillary is pushing fluid out, but it's not being brought back in. And so we see this with ascites. So with ascites, we have this large volume of fluid out in third spaces that we're not being able to brought back in with the oncotic pressure. So I would expect my patient would have a low blood pressure and a high heart rate. Since the fluid is in the third space within the peritoneal cavity, their blood volume is going to drop, which drops their venous return, which drops their end-diastolic volume, which drops their stroke volume. When their stroke volume drops, that's going to drop, of course, their blood pressure, their measured blood pressure. However, in response to that, what I'm going to see is the heart rate is going to try to accommodate that. And so they need to maintain a set cardiac output. So the cardiac output equals stroke volume times heart rate. Well, I can't maintain my stroke volume because my volumes are too low. So what I'm going to do is I'm going to increase my heart rate in order to maintain their cardiac, or for them to maintain their cardiac output. So there's different things that can cause low blood pressures, but typically you will see, in association with low blood pressures, you will see high heart rates. So when we look at what causes low blood pressures, first of all, we think of things like fluid loss, volume loss. And so it could be that the patient is bleeding, they're hemorrhaging someplace. So when you have a patient that has been injured, maybe traumatic injury, sometimes that low blood pressure and higher heart rate are telling you maybe there's a bleed someplace that you haven't addressed. Other things that can drop your volume is if you're having decreased fluid intake. So you're just dehydrated. You're not bringing in enough fluid, and so your blood volumes are dropping, your heart rate's increasing to accommodate for that. The overuse of diuretics. If I'm over-diuresing a patient, they might have too much fluid loss, and so their heart rate, their blood pressures are dropping, their heart rate is increasing. Other things that could do it is if I have a patient that I'm not familiar with, but they come in with low blood pressure and high heart rate, I might think of things like maybe diabetes insipidus, hypoalbuminemia, anyway, anything that can drop these volumes, or of course the loss of oncotic pressure. Okay, so usually again, if you're blood pressure is low, your heart rate's going to be high. And this is usually due to decreased volumes for whatever reason. It could be, again, lack of fluid intake, fluid loss, blood loss, loss of oncotic pressure. Now, on the flip side of that, if I have high blood pressure, then I would expect my heart rate to go down. Now, note that this is usually at rest, because when a patient increases the activity, a lot of times both of these will trend together. But at rest, I have a set oxygen demand. And so my stroke volume heart rate are going to equal my cardiac output, and these are inverse. So at rest, if my blood pressure is going up, typically my heart rate will start to go down. So when we think about situations like that, here I've got someone that is fluid overloaded. And so the fluid overload has increased their blood pressure here, increased the activation of the nucleus of the tractus solitarius, increased the activation of the nucleus ambiguous, which has increased the release of ACH from the vagus nerve, and increased the hyperpolarization of the SA node. And then, of course, going back the other direction, I'm also decreasing the release of norepinephrine onto the SA node. Well, in some instances, you might have them both trending together. So I might have a patient that has an increase in blood pressure and an increase in heart rate. Well, then I have to think, okay, what can cause that? Because that's not an inverse relationship. And so maybe there's a different driver. So some of the things that come to mind are things like pheochromocytoma. Because on the kidney, you've got the adrenal gland, and the adrenal medulla releases the catecholamines epinephrine and norepinephrine. If I have a patient that has high blood pressures and high heart rates, but their EKGs are normal, then I'm starting to think, man, maybe the catecholamines are being released, because pheochromocytoma with the epinephrine and norepinephrine can actually drive that forward. So that patient needs to be pharmacologically managed until they can address the tumor on the adrenal gland. Other things that might cause an increase in blood pressure and heart rate could be some type of neurological disorder that's affecting the system up in here, where they're no longer having that inverse relationship. Now, on the other way, we can also get a decrease in blood pressure and a decrease in heart rate. So usually when you're looking at stuff like that, you're looking at somebody that might be on a sympatholytic agent. And so we told you before that sympatholytics are adrenergic antagonists. They break the sympathetic response. And so you might have something that's blocking the release of norepinephrine. You might have something like a calcium channel blocker. They might be on either a calcium channel blocker or a beta blocker. And so the beta blocker is bringing both the blood pressure and the heart rate down, because both of these are mediated by beta-1 receptors. Because here we have a beta-1 receptor for norepinephrine on the SA node and a beta-1 receptor for norepinephrine on the myocytes. So by administering this beta blocker, I'm dropping both of these. Other things that can do it are your antidysrhythmic agents like amiodarone. So anyway, so that's what we're going to talk about, or what I wanted to discuss with you, as far as just be sure and kind of know this system, this feedback system, because once you understand the system, you can kind of look at what's taking place to make determinations about your patient. And so in the next video, we're going to look at respiration.